Hey everybody, welcome back to Mike and the Doc. I'm Mike.
And I'm the doc.
All right, guys, today's episode is going to be around a really hot topic called MAiD, which stands for medically assisted in dying. It is a very polarizing topic. The people that are for it are very for it. The people that are against it are very against it. If you guys are watching, don't forget to like, comment, and subscribe. Stay up to date, and let us know your thoughts on MAiD down in the comment section below.
So Trevor, thank you again for a crazy, oh my gosh. Wow, what a topic. What a topic.
The homework.
Trevor comes up with the best and most difficult homework. Okay, so medically assisted in dying. Okay. So, I don't want to get right down to, I don't want to play the middle because I think that our viewers deserve more. But I do see points on both sides. As far as what we do, I think, and maybe it's because we live here and it's what I've been doing for so long, but there are specific criteria to get you into hospice, right? And even when you get into a hospice, it's not like I think a good way to look at it is, let's just say you have a patient who has lung cancer with Mets to the brain, okay? Mets to the brain, which is bad, and Mets to the spine. So these are lesions that have gone to the spine where your interpretation of pain goes, right? So hospice is more like you have pain, we give you a pain medication, and it might cause you to breathe less. And so what we do, at least here, is we're not like, oh, you're breathing less with that much. I gave you, I don't know, like 10 of morphine. I'm going to give you 100 of morphine for the next one, right? Like that's not how we do it. What we do is if 10 of morphine makes you a little bit hypoxic, your oxygen level goes down, your mental status goes down, then maybe the next time we'll use 5, but our focus is on keeping your pain well controlled. But we're still using a little bit of clinical judgment not to use too much. So I really like what we do, but we don't, if 10 works and makes you really hypoxic, we don't give you 100 because that is literally like pushing them into death, right? So, and then you also, in addition to that, we obviously have to work in the Medicare guidelines and that sort of thing. They also have to meet specific criteria. So the arguments that I saw for medical assistance were the guys who were pro were all about, hey, we want to take your pain and suffering and we want to alleviate your pain and suffering, right? Which is what we love, right? We love to do that. And there were also, the other thing is when we talk about like a system, whether it's in the US or there's a lot of Canadian videos that we watched, but like whether it's in the US system, Canadian system, is access, right? If you can't get access to hospice, or God forbid, you have a terminal diagnosis, and I hate to say it, but I think I've seen this too. You have a terminal diagnosis and you need hospice and you're waiting to get on hospice. That's terrible. You should never die while on a waiting list. And actually what we push is that you won't wait for us. At Connolly Care Hospice, you won't wait for us. Like, if you qualify, we'll have somebody come and see you, and you won't be on a list, right? And there are some patients that die immediately, but I feel as a company, try our best to get you on as soon as possible, right?
We can admit them same day.
Yeah.
Or our standard is within 24 hours.
Yeah, and we're small enough that we can maneuver like that.
And why would a patient not qualify for hospice if they need it?
So, for example, you need to show a diagnosis that is terminal. Let's explain that. So you have lung cancer. I always just go back to lung cancer, easiest one for me to figure, right? Lung cancer, mets to the brain, right? Even with chemotherapy, if it's like a small cell, if it's a specific kind of cancer and it's gone to the brain, even with whole brain radiation, even with chemotherapy, you're looking at like, I don't know, 6 months. And so
Wow.
you can either go through that whole rigmarole, or you can just say, listen, I've lived a really great life. I'm going to go on hospice and I'm going to enjoy what's left. And the 6 months, and by the way, the 6 months that I do have are going to be in the hospital with nurses poking and I'm not going to do, like, I'm just telling you my own opinion. I wouldn't do that. I don't want to be in the hospital getting poked and prodded. I want to be at home with my kids. And, you know, when it comes, it comes. And what people might be thinking is, oh, well, what if that happens in a month? Okay, so be it.
Right.
So be it, because it's not about the quantity, as we all talk about. It's about the quality.
That's
right?
I had a doctor put it like that, and I thought that was the best description. Would you like more quantity of life or more quality?
Oh, yeah.
And that makes sense to me.
Yeah, and you're at home. Come on. It's like,
One more trip to the casino.
You bet it all.
One more trip to your favorite restaurant or your grandkids' home.
Yeah.
It makes sense.
And we can do that on hospice. We can do that on hospice. So there's definitely a lot of good reasons to be pro. Okay. Then there are the people that are anti.
And you mean pro MAiD, right?
Yeah, pro MAiD, like I'm pro for those reasons that I had mentioned. Okay. So yeah, to your point, Trevor, like pro MAiD. Okay. The people that are anti MAiD, they actually bring up some really fantastic points too, I think. So, in Nevada, we'll just say there are a lot of criteria to get on hospice, and we don't euthanize, right? If 10 works, we use 10. But if 10 doesn't work and we give you 20 and you become really hypoxic, but your pain is well controlled, well, that's what we want. That's the goal. The focus, the goal of hospice is to keep my pain under control, keep me comfortable. So getting back to the people that are anti-MAiD, if you have somebody, so they're also talking about opening it up to mental illness, okay? Or lowering the age. Okay, so I'm thinking of a patient because I like to think of examples that drive the point home in one patient. So you drop the age, right? Let's just say you drop the age below 18, okay? And you drop to somebody who's depressed, right? Well, as a family man who has exposure to lots of different ages, right? Think about a young girl, right? Sub 18, who's going through, say, body dysmorphic disorder, right? And they're depressed, just because that's the way society is. It's terrible. It's not fair for girls, period, point blank. And a lot of these girls want to commit suicide. Like I see that all the time in the hospital. Wow. So if you lower the age and you take out the terminal diagnosis, you're going to have a lot of people who are depressed who might not be in their right mindset who want this therapy. This assistance in dying. And I guess the point I'm trying to make and the point that I feel is relevant here is that if somebody is depressed, and this is a problem in Nevada, I think, as well as many other states, but if you're depressed and you want to see a psychiatrist, you got to wait. You got to wait to see a psychiatrist.
I've heard that we don't have as many as we need.
That's like, it's just pandemic throughout the states. So if you have depression, in a perfect world, a young girl with depression comes in and says, hey, I'm suicidal, I cut my wrists, I did whatever.
Wow.
And I need help. And that's what you want, is you want them, like, unfortunately, some of them don't even reach the hospital. But if they do and they want help, they should see a psychiatrist. And then they have a shot. But if you don't have access to outpatient psychiatry, then this is somebody who's already shown you that they're suicidal. And then if this option exists to them, they might use it. Whereas and this is my opinion, we should treat their depression, right?
I like that.
Right?
Leave it up to the doctor.
Yeah, or another one. Another one is a veteran. Okay, this is a really interesting one that I heard about, right? Is a veteran, you know, you go over, you fight war, these young kids, it's you know, war is terrible. Like even the war that we're currently in, terrible. Okay? But you send these young kids into a war and they see things they've never seen and they can get PTSD, right? Now, what if you have a 25-year-old, let's make it a little easier. Let's just say we have a 20-year-old kid, so over the age of 18, 20-year-old kid from some little town in the Midwest. I'm just using this as an example. He has a family, young family. He goes over and sees some stuff that he should never see, right? Basically things that you see in war, right? And war is horrible and terrible. You'll probably get that from the way I'm talking about it. But they see things that they should never see. And they get PTSD, and then they can't function anymore in normal society. So if we think that a private person has a problem seeing psychiatry, these poor vets, they really have a problem getting to see psychiatry.
Even worse.
Even worse.
Even with the VA system?
Potentially much worse. And so
Because it's backed up?
Backed up, and you know, there's so many.
And how about the pride? Do they have pride in seeing a psychiatrist?
That's a really great question. So I think that pride thing is something that's going to die with us. You know, I'm obviously older than you, Mike, but you know, I think it's going to die with us. Our generation was very reluctant to consult psych, right? Or hey, I'm depressed. Like we never did it.
Or even a consult as a doctor?
No, I'm saying like, let's just say I felt depressed. I had clinical depression.
Right.
In my age group, we typically don't.
You don't go for help?
No.
Right.
But I think the generations below us, they're much better at doing that.
Immediately.
Like when they need it. Yeah.
Right.
Yeah.
Are they overdoing it?
That's like, so from our perspective, maybe they're overdoing it. But
I
that's
don't want to go to school, so I want to see a psychiatrist today.
Right. Yeah, no. So that gets to your point. Like the guys who are anti-MAiD, they're going to be like, hey, and like getting back to the veteran example, well, that's not a good example. But like, let's just say you are obese and you have osteoarthritis and you don't have a social life and people make fun of you and therefore you're depressed, you're suicidal. You technically could say, well, it's irreversible. Why? Because I've tried this, you know, these patients that have tried for years and years and years and years to try and get skinny or, you know, for their health, get away from morbid obesity, they can't. So so you could say that it's irreversible, right? So I don't love that because then the guys who are anti-MAiD are going to say it's a cop-out, right? Like, oh, you can't handle life. So since you've tried to lose weight for the last 20 years and you are, quote unquote, let's say you're like 35, and you're depressed and you feel there's no hope and you just want to kill yourself, well, maybe we should make that mechanism, with the people that are anti-MAiD, say that mechanism is too lax. And then coming back to the veteran in this one scenario, so a veteran goes to whatever war-torn country, and sees things that they shouldn't see, comes back, has PTSD. This argument, these are all anti-MAiD people. This veteran apparently was doing just fine. He had PTSD, but he was doing just fine. And so then the person who was interviewing the veteran, this is really where it gets sticky, so sticky. They said to him, hey, you know, we have somebody who had probably some sort of PTSD, and we assisted them. And because they were assisted in death, they're in the army or whatever, there's benefits for the family. So what a slippery slope, right? You take a young person who's probably depressed from PTSD, might think that there's no hope, And then you add on that, hey, listen, if you do this, then your family is going to get benefit. Like, I hate to say it, but as a dad, I can totally see why that would be awesome, that my family gets this awesome benefit, like money, in the event of my death. And like, okay, so I say, I see why that would entice a veteran or anyone that's young with a family. But like my own issue with that is that, well, I want to be with my family, but I'm not depressed, and I do not feel like there's no hope. So, but if I was depressed and I felt like there was no hope, and I felt like I'm just a burden on my family and the rest of society, and hey, I can do this thing, and hey, my family benefits. You see what I'm saying? That's a slippery slope.
I do.
And that's what the anti-MAiD people are going. So what I'm saying, Mike, is I see the reasons for both. I hate to play the middle.
Very good point there.
Yeah.
Very good point.
What about you? What are your thoughts?
Well, that's a good. It was a heavy topic.
Oh, Trevor, these topics.
I didn't know what
got
I
more
was
lined
diving. I didn't know what I was diving into. I took a little guess in my mind, but yeah, Trevor sent us some great. He sent us an article, plus some videos, and I really enjoyed the article because I didn't know that it was offered in so many countries, and I didn't know Canada was so heavily involved, with them being our neighbor and us kind of working with them more than other countries. I didn't. I knew they had the socialized medicine, which I know there's problems in waiting and getting care, but I didn't know that this was being used more heavily. So
They dropped the age and they included mental illness.
yes, I saw that, and 2027, they're gonna go with mental illness that you could have MAiD. I don't know if that's been approved yet or not, but the thing that I had a hard time with was if somebody has the lower level mental illness, anxiety, depression, to approve that for them. Now, I know depression can, like you were talking about, it can be a lot less lower level. It can be higher level depression, very debilitating for the patient or the family. But somebody that just has anxiety, and I'm sure a lot of us qualify, right? Having families, having more than 40-hour-a-week jobs, I'm sure all of us have a little bit of anxiety. So does that mean we could just step over and go for MAiD because we're a little bit anxious? I would have a hard time agreeing with that.
I think what we're both saying, I think we both agree that there should be a lot more oversight, right? But the problem with oversight, so this is the reason, so I understand both viewpoints. The problem with oversight is that you could have somebody who just can't get access, we'll say to, let's just say lung cancer patient, in a place where there's lung cancer patient, they don't want to do chemotherapy for the reasons I had mentioned, and they want assistance in dying, okay? Well, what if they can't get access? What if they can't get access to hospice? Because, or whatever, or palliative care, because they're sick. Let's just say great example. Let's just say their prognosis is 6 months, and the first time they can see palliative care and hospice is 12 months.
Right.
Well, they're screwed. And so that's a systems issue. So I agree that we need to be careful with these really, I'm going to call them soft indications for MAiD, because then we're putting too many people into the death slot. But if we add too much for them, add too many criteria, then the other side of the coin is that people won't get what they need in a timely manner. It's a really tough, and again, like you had said before, leave it up to the doctor. And of course, I love that because my bias is I'm a doctor and I love that. However, it's being a little paternalistic, and we're both dads. Paternalistic is like, the pa is father, right? So paternalism in medicine is when, let's just say, you're the doc and I have cancer. And I know, because I looked it up on the internet, I know that squamous cell cancer with mets to the brain, you're basically, you're done. Like, I look over people, what they did, and people got chemotherapy and it sucked. And, the last 6 months of their life, yeah, they got 6 months, but 5 of them were in the hospital. I could say to you as a doc, your recommendation could be, well, we have this, we can't cure it, but we can decrease the size of the lesions for your comfort, or we can give you whole body radiation and chemotherapy. And then I could just be like, listen, I don't want that. As the patient, I could say, I do not want that. And then, so paternalism is when you, as the doc, think that a patient should get a therapy, but then the patient doesn't want it.
I see.
And it's a very subjective thing, right? Because, contrast that with, let's just say I'm the doc and you're the patient. You're depressed, clinically depressed by every parameter. You've gone to 3 doctors that have diagnosed you with it. You've been to the ER 5 times to try and kill yourself, okay?
Wow.
But you refuse to take anti-anxiety pills or depression medications because you don't like the way they make you feel. Well, you see what I'm saying? So there are different levels of paternalism, right? Like, in one case, I can totally see the reason for the patient not wanting the treatment. But in another case, I can see, and I see this a lot, I can see the reason for an argument for the doctor should be listened to.
And
Yeah.
I'm kind of curious because it's kind of presented as a replacement for hospice and palliative care. How do you guys feel about that?
Well, I was just thinking about hospice, and I really like how it's set up where I like to say, does the patient fit in the box, the box of the criteria? So we have a number of criteria with certain diagnoses, COPD, congestive heart failure, where if the patient doesn't check every box, they're not hospice appropriate. So I would say, in my opinion, I'm not a doctor, but there's got to be some sort of box that could be used, and obviously patient consent. But really, I'm kind of in a gray area on some of this because number one, it's very sad, and you mentioned putting our own daughters in your mind, and just to approve that, I can never approve it.
Right.
It's just you'd want to do everything you possibly could to reverse the depression, reverse the anxiety. So yeah, I think there's got to be some set of guidelines, some criterion that's made by a doctor that would be like the hospice box that we use.
And I think that's a really great point, is there are criteria to even get on hospice, right? Which, you and I know very well. Because basically, we still don't do euthanasia, right? What we do is you're giving us the permission. If you go on hospice, I, as the doc, have permission to focus on pain. And again, if 10 of morphine works, I don't need to give them 100 of morphine, because that goes into euthanasia, right? Because let's just say I'm the patient and I have pain, and you give me 10 of morphine and my pain's well controlled, but my oxygen levels are really low. Well, for the doc to give me 100 of morphine will most certainly kill me, right? We can't do that on hospice, and we certainly can't do it in this state. So to your point, I do like the fact that there are a lot of criteria, but on the flip side of the coin is the more criteria there are, the less people that get in. So that's a good thing. But then there are going to be people that really need to get in that don't get in because of all the criteria. Do you see what I'm saying? Like,
I do.
I hate to play the middle, but that's kind of where. So I am actually very pro having people look at it because, for example, there is some group of adolescents. So these are the people that are set up for suicide, right? So what I'm trying to say is a time in your life, we were all adolescents, right? You're 13, you're 14, you don't like the way your body looks, you're sweating, you have facial hair, but nobody else in your class has facial hair. You have breasts, but nobody else has breasts, or you don't have breasts and you're a girl and the other girls do. Like, this is just a really tumultuous time for adolescents, and there's a lot of depression and suicide at that time.
Wow.
So there was some group of adolescents that were waiting for the age limit to be decreased, and they had like a suicide pact.
I saw that. I saw that in one of the videos, and unbelievable.
Yeah, very, very slippery.
So I was actually kind of curious about the religious implications that you think this could do, because I know a lot of Christianity and branches of Christianity preach suicide as a sin. Maybe not explicitly, but it's like God brought you in and he's going to take you out. And if you go against that, then there could obviously be repercussions. Is this like a gray area, especially if you're in the States, somewhere like California, where they just give you medication to take it home? At the end of the day, you are dying by your own hand versus getting euthanized by a doctor, where it's still your choice. So I don't know. What are your religious takes on this? Like, do you think somebody that chooses this ends up?
Well,
I'll let you start with this one, Mike.
I grew up, I did a lot of Catholic school, so I was always versed with those 10 commandments, which I still try to live by. Like we've talked about, I'd say I'm more spiritual than religious. Meditation and prayer has become much larger parts of my life. And thou shalt not commit murder. That could play into the doctor, right? The doctor may have a big problem with that if they're following those 10 commandments. Or I talked to a pastor. There was a pastor, I won't name anybody's name, but he said if you accept Jesus Christ into your life, that their religion is okay with suicide, as long as you've accepted Jesus Christ. And that was kind of a new take. It wasn't the Catholic religion. It was another religion. And so I said, hey, well, I'm in good standing. I've accepted Jesus Christ. And but again, this topic just, I wouldn't say irks me, but it really it makes me kind of go into different parts of my mind, because I'm okay with hospice. I think because I've grown up around it and I've gotten so acclimated to it. But then now this, I don't know, I get more of an eerie feeling when we're talking about sending people home with a cocktail that's going to kill them, or allowing them to sign up for the euthanasia. It's I think what I would say is that if there's no other option, almost like hospice, right? You got to qualify. It's got to be the last 6 months of your life. So again, going back to the box, you check all the boxes. You've went to 3 Dr. Ali's. They've all said the same or roundabout the same. Then I would have to say I'm okay with it.
Yeah, Trevor, the way to keep it controversial. So we brought religion into this, and we were talking about biblical, right? So Jews, Muslims, and Christians, right? Sorry, Jews, Muslims, and Christians. So they all follow a central book, right? That's biblical. And I don't think of any of those 3 major religions anyone approves of suicide. Not to my knowledge. I know you were talking about some offshoot of Christianity, but to my knowledge, and correct me if I'm wrong, because I'm certainly not an expert on any of these, but basically I think what you're getting at, Trevor, is that most, if not all, major religions do not approve of suicide. And that comes back to what you're saying, Trevor, is that God gave you this life, and so it is up to God as to when he will take it. So you're right, Trevor. I'm like a spiritual person. And so I guess kind of in the same vein as, well, if I'm depressed, let me do something about that. I'm going to try and do something about that. And in the same vein, I'm a spiritual person, and the right to my life is not mine. Because, like, for example, myself, I wouldn't take my own life, right? Because I'm of the opinion for myself that God gave me life, and so it is up to God when that's taken away. However, I've never had lung cancer that's metastasized to my brain or my spine or my bones. I don't know what that pain is like. So who am I to tell a patient even that your pain is not, I don't want to say suicide worthy, but not worth you taking your life? So it comes back to that patient can go on hospice in our state, and we don't euthanize them. So actually, the way that it's set up right now in Nevada is very congruent with my spiritual beliefs and also my beliefs as a physician. It's a real slippery slope, right? Because again, we come back to paternalism, right? Like, or even grades of depression, right? I've never been depressed. Who am I to tell somebody that, you know what, like they just can't function? There is a level of depression where you just can't function. And you put them on so many meds that when you see them on meds and they don't want to kill themselves now, they're like zombies.
They can't leave the bed.
Yeah, like catatonic or
catatonic.
Oh man. So I don't know, but what I can tell you is that maybe a psychiatrist could ferret that out, but I can't ferret that out.
What is it like in the ER these days with psychiatry? Is there somebody on call always?
Great.
How does that look?
So if you come in and you're suicidal, I've had many patients, but I'll just use I'm going to say it's a fictitious example. Okay. So I had a patient come to the ER. They were a young female. They've tried to commit suicide 3 times before. They come back in. They took all their Prozac. They took all their Atarax, and they even drank and took some Tylenol. Okay. And they slit their wrists. Jeez. And they're suicidal. They have suicidal ideation, and they have a plan. The plan was the drugs and cutting their vessels, right?
Wow.
So what happens in that kind of case is we could put them on what's called Legal 2000. So that's an L2K, and that basically takes away their right to leave the hospital. And so anyone can initiate it, but the way I like to play it, every physician's different. I can initiate it, and it's a big deal because you're taking away their rights for 72 hours. Like, I'll get to another example, but on Legal 2000 for 72 hours, the patient cannot leave the hospital, even if they wanted to. So they go on Legal 2000, and then a psychiatrist should be able to see them within that 72 hours.
I see.
And then they make an assessment. Oh, this patient is suicidal. Continue their legal hold or discontinue their legal hold, but then admit them to a psych facility.
Do you think that the implementation of MAiD would trump an L2K? Like, obviously, it's like, oh, I'm not going to let you leave because I don't want you to off yourself. But if they opt for MAiD, then there's kind of no point, right?
Interesting. If I don't know, Trevor. I hope that if they're suicidal and they're in the throes of their suicide. So like, for example, bipolar, right? Bipolar, you're either manic at the casino, spending all your money, getting into the sports car that you can't afford. That's the manic episode. Okay. Then there's the depressive episode. So bipolar, manic, depressive. So you're doing like the gambling and maybe like gambling, getting cars. You're being very promiscuous when you're manic. And then depression's on the other side where you're really depressed. So that's the bipolar. So if you are now in your depressed state and you want to kill yourself, well, we know it's part of your bipolar, right? So I hope that it's somebody like that wouldn't get through the criteria to get onto MAiD. That's, do you see what I'm saying?
Because you don't really think they're appropriate.
They're not of the right mindset. But the people that are anti-MAiD would say, well, what about that patient? That by some way, they find two docs that agree. You know, how hard is it to find two doctors that agree that the patient is super depressed, they've tried to commit suicide at home, they have no options, we can't effectively treat this depression because they've been to 15 psychiatrists and they've been on meds for the last 15 years and they're still suicidal. You know, it's a slippery slope. You get two docs that say, oh yeah, it's depression that cannot be fixed or treated, then the people that are anti-MAiD would say, yeah, they're going to get in.
And that was kind of a weird point that was brought up in a lot of those articles was somebody comes in a depressive state. I've been there before where I went through depression and anxiety for 8 years, and there was points where I felt very low. I didn't want to die, but I didn't want to live. It was a very weird feeling. And it's like if I ever went into the hospital, they would obviously try to help me, but MAiD has introduced this weird thing where it says, if you want to wait for treatment, it's going to be 6 months. But if you want to do MAiD, we can get you in next week.
Wow.
Yes, that's really slippery. I feel that not anyone, but whether it's the Canadian system or the U.S. system, I feel like you have to, as a society, be able to offer these services, right? But on the flip side, because there's a flip side, right? How long, let's use lung cancer. I get diagnosed with lung cancer today, squamous cell carcinoma of the lung.
What is squamous cell, by
It's
the
like
way?
the worst kind of lung cancer. Squamous cell is the description of the cell when they look at the cancer cell. Sorry. Basically, bad lung cancer that is not really treatable and your prognosis less than 6 months. So those are the kinds of people we'd see on hospice. So you could technically say, if I was a paternalistic doctor, I could say, well, listen, there's going to be a treatment for lung cancer. It's just on the horizon. It's going to come out in 2 months. But when it comes out in 2 months, not everybody gets it. When it comes out in 5 months, maybe it goes to the big teaching centers. And then in a year, when it's available to the public, you got to have $100,000 sitting in your bank account to even get this experimental treatment. So there's another slippery slope. You could say, oh, we don't do this, but if you have end-stage dementia from Alzheimer's or what have you, somebody who doesn't understand it, who is not in the field like you and I are, could say, oh, well, what if there's a treatment for Alzheimer's, like some new treatment that totally takes it away in the next 2 months? Well, then you wouldn't have given the patient that chance, right? But the flip side to that is that they want to do MAiD too quickly. They're not willing to give it a chance. Somebody who's depressed and they've tried medications for a month, that's not really giving it a chance. But that's my opinion, right? Our duty as a society is to be able to get the veterans the psychiatric help they need. Our duty as a society is to be able to get patients who need hospice on hospice in a timely manner. Our duty as a society is don't let a person who's old with Alzheimer's feel marginalized, right? Maybe us as a society, you know how it is here, right? It's very different than in other countries. But here, if you're old, it's not great. The words like burden, nursing home, all these things. Whereas in other societies, so if you're an elderly person in Japan, you're kind of like a big deal. Here, if you're 90, you're not a big deal. You're kind of marginalized. And you could see, for the people who are anti-MAiD, you could see how a person who's elderly, who feels that they're a burden on their family, would say, yeah, I'm going to do MAiD. And then it's our duty as a society to make sure that elderly person doesn't feel marginalized. they feel good about themselves. They feel like, no, I have 99 years of experience. I can impart this onto my kids or my grandkids or whatever. Society can benefit from what these elderly people can give them. And so we need to change, especially in North America, we need to change our interpretation or the way that we treat our elderly.
I agree.
All right, guys, we're going to wrap up the episode here. Just final thoughts. I want to get your definitive stance on MAiD. And it's okay if it's a bit of a gray area, because I mean that's kind of where I'm at. You know, I see the benefits for some and the cons for others. So I'm just curious as your guys' final thoughts on the whole subject.
I'm going to go ahead and side with Trevor there. I think there's a middle ground. And again, I just want to go with, I feel strict guidelines need to be made. Maybe talking about the box like we use in hospice, the hospice box, the qualifiers. And if somebody does meet those qualifications, then I would be okay with it. But outside of that, I wouldn't want to approve just because you've been depressed for 30 days.
Agreed. I think I'm in the middle as well. I see the viewpoints for both sides. I think if we could have more criteria or a lot of oversight, but do it in a way such that the people that need the help can get it, I think that would be a great option. I think as a society, if we could help our veterans and our marginalized populations, whether they're old or the psychiatric patients that really can't talk for themselves, because, why am I going to listen to them? They're bipolar. We need to really help them. And then another thing that I thought was really important about hospice is that just because they're on hospice, if they do better, we discharge them off our service. We had a couple that
we have.
So I know it's easy for me to say, but I really like our system here, because even if you go on hospice with a terminal diagnosis, well, hey, some people live 6 months, some people live 1 month, and some people live 6 years. We don't, like the docs, we don't have crystal balls, right? But if you have a terminal diagnosis and you are doing so well on hospice, in our system, we discharge them from the service, and then they can do their thing. And that, what I'm saying is, even if they discharge from the service, that doesn't mean they can't come back, And then the other point, the flip side to that is, if they're on hospice, that doesn't mean that they can never say, I don't want hospice anymore. And we've been really good about that. We've had a couple of patients leave our service because we thought they were doing so well. And who are we to be paternalistic and say, oh, no. You think you're doing well, but you have this lung cancer diagnosis, so you will stay on hospice forever. We're not like that. We're like, oh, they're flying. We're happy. We're happy to help them in their transition into the afterlife or whatever their belief system is. And we're happy when they beat the odds and they do well and get off hospice.
Yes, I think the transitions have been done very well.
Agreed.
All right, guys. Well, I appreciate you sharing your thoughts on this. I'm glad it was a thought-provoking task that I gave you for this episode, and very polarizing subject, but I appreciate you guys sharing your thoughts on it. And to the viewers, thank you guys so much for checking us out. Don't forget to like, comment, and subscribe. Let us know your thoughts on MAiD, how you think it can be implemented. And thank you guys.
Thank you, Trevor.
Thanks, Trevor. I'm sure the next topic will be even crazier.
Just got to wait and see.